My name is Dr. Kevin Mange, and I'm the head of North America Medical Immunology for Sanofi Genzyme. It's a pleasure to be here this morning with you, and thank you so much for joining us this morning as we talk about rheumatoid arthritis as a disease that's more than just a disease of the joints. Before we get started, just full disclosure, I am an employee of Sanofi, and I hold equity interest in the company. So this morning, we're going to spend a little bit of time talking about RA as a complex systemic immunologic disorder, just to kind of level set everybody that they understand that, yes, it is a disease of the joints. Then we're going to move quickly into talking about RA as a disease that extends beyond the joints. It affects multiple organ systems. And then this relatively new concept that has been integrated into the American College of Rheumatology guidelines of treating patients with RA to a disease target, to a level of severity. And then we're going to quickly move into how the level of RA disease severity relates to healthcare utilization and cost in the United States. That we see consistently across studies that the higher your level of disease activity of RA, the higher your level of utilization of resources is. And that's not only in the US, which has only recently been discovered, but it is consistent with the data that have come out of Europe over the last several years. So when I say rheumatoid arthritis, I think everybody in the room and perhaps in the hallways, you think about the joints, right? So arthritis is inflammation of the joints. And classically, it will affect women more than men in their 40s to 50s. It affects about 1.3 million people in the United States. And if you sit and talk with a patient after they've been diagnosed with RA, what were your earliest symptoms that you had? And often as you sit and talk with them, their symptoms that they have at presentation relate to how stoic that patient is, relates to their pain tolerance or intolerance, as the case may be, and also how active that individual is, because people present with a spectrum of symptoms, as you can see here on the slide. But one thing they'll say consistently is when they wake up in the morning, they're stiff. It takes a while for them to get going. And so what does a while mean? So classically, it's more than 30 minutes. So it's not I need my cup of coffee before I get going in the morning. This is something when they arise and they shower, change, breakfast, what have you, they are stiff for quite a while. And it's a reflection, as what you can see here in the slide, particularly of the hands, of inflammation of the joint lining or the synovial membrane, hence synovitis. Now that stiffness progresses to tenderness, all right, on touch or on palpation. And then if you look at your own hand joints, you can see they're pretty well demarcated. Right? You can see your knuckles pretty clearly if you have normal joints. But if you have swelling of these proximal interphalangeal joints or metacarpal phalangeal joints, they're swollen at times. They're boggy. You can't see that demarcation anymore. And then when they progress to pain on motion, so classically, if you're opening a jar, all right, pain in the hands because that torque force puts a lot of stress on these joints. That limits their motion, and for often many people, the pain, swelling, tenderness, what have you, impairs their activity of daily living. Now, how that patient presents, if we're talking about a couch potato, all right, they are going to typically present a bit later. Why? Because they're not moving. When they start to move, they have pain. So it's kind of a negative reinforcement. So they present later with symptoms, such as pain, joint swelling, for an example, as opposed to a very active adult with raising a family, working, nonprofits, community work, what have you. They may be too busy to come to an office, all right? Or they may notice that they can't do what they need to do. So again, the presentation is pretty broad. Now lastly, I've been making reference in the figure here and to myself, hands. But there's a significant minority of patients, if you will, foot and ankle symptoms. All right, it's a disease that affects the peripheral small joints. Well, joints in the feet and the ankle itself are also small joints. So that can become a diagnostic dilemma for the primary care physician. But you can see how that would impair someone's quality of life as well. Some adults, when they have a flare of their chronic inflammation, their flare can start in their feet, and then they'll flare in their hands, interestingly. So again, it affects hands and feet together. And I should also mention that what we're going to be talking about this morning is really the arthritis, the rheumatoid arthritis of adults. Okay, we're not going to be talking about juvenile arthritis. It's a different disease, different presentation. So again, I'm making reference to adults with chronic rheumatoid arthritis. As you can see here in this figure, it makes reference to what I was just saying, that chronic inflammation that you see here in brown is ongoing, and it can significantly impact an individual's ability to function in society or the level of disability. Now, if that chronic inflammation goes unchecked, what you'll see in the yellow boxes here are changes on x-rays of the hands, feet, and ankle. So that chronic inflammation in the joint, right, synovial lining is inflamed, it starts now causing erosions in the bone, joint space narrowing. Now later on, that joint destruction becomes a significant determinant of the disability, but underlying that is the ongoing chronic inflammation. So if that chronic inflammation goes unchecked, joint damage occurs, and important to recognize is that joint damage is irreparable. All right? It is irreparable. So early on, inflammation, if unchecked, it progresses to joint damage. And you can see here on the right part of the slide just some visual of swelling of the proximal interphalangeal joints, that can progress to active deformity. And the bottommost picture here, this individual we should no longer see in this day of age, right? Newly diagnosed RA patients should never get to this point. Subluxation or dislocation of the wrist, ulnar deviation of the fingers, as an example, we should no longer see that in patients who are diagnosed today with RA. They should not be allowed to progress. All right, so RA is a disease of the joints, but that's not the full story. RA as a disease affects several other organ systems. I have several examples here we're going to talk a little bit about that support that this is a systemic disorder. In fact, when you measure markers of systemic inflammation like highly sensitive C-reactive protein or erythrocyte sedimentation rates, they're high, right? And they get higher and higher if that inflammation is unchecked. Now, we're not going to talk about the bottom two, hematologic disease and renal disease. With the high inflammatory states, we know that hepcidin as an acute inflammatory marker goes up. It binds iron. Iron can no longer be utilized in erythropoiesis, so they become anemic. All right? Felty syndrome, neutropenia, splenomegaly is another example. It reflects that this is a systemic disorder. Kidney disease, very uncommon. You have to have many, many years of sustained RA that's unchecked. Renal amyloid or glomerulonephritis will develop, but again, it's very uncommon. But the point is not about its infrequency. The point is it reflects that RA is a systemic disorder. Let's talk about some of these other organ systems quickly. There's a broad spectrum of cardiovascular manifestations in rheumatologic diseases. Why? Because they have a high inflammatory state. So in the cardiovascular system, you have involvement of the pericardium, the myocardium, the endocardium. You can also have involvement of the valves as well as the electrical conduction system. So in RA specifically, You can have inflammation of the pericardial lining, so lining outside of the heart. You get pericarditis and pericardial effusion. Now, yes, often it is asymptomatic, undiagnosed, but that's not the point. Pericardial inflammation in an RA patient is a reflection that this is a disease that goes beyond the joints alone. If we look at valves, we'll talk a little bit more about rheumatoid nodules when we get to the skin, but if you look at valves in the heart, if they develop nodules, those valves are incompetent. They don't close completely. You get regurgitation, you can get dilatation of the chambers of the heart that leads to other consequences. You can actually have nodules in the electrical conducting system, so you get atrioventricular blocks, for an example. Now, if you look at the bottom right part of the slide, with the high inflammatory state of RA specifically, you have high levels of cytokines such as TNF-alpha, interleukin-6. It causes atherosclerosis, accelerated atherosclerosis, for an example. And that's not surprising, right? We've known for the last 15 years from work done in Boston that outside of RA, that patients with increasing levels of CRP, specifically highly sensitive CRP, that those patients are at higher risk for cardiovascular disease. So an inflammatory state can be an independent marker or independent risk for development of cardiovascular disease. So it is not surprising that RA is a high inflammatory disease, puts patients at higher risk. So what data do we have to support that? If we look at some data from a little time ago from Mayo Clinic in Rochester, Minnesota, they took over about 600 patients with RA, matched them to age and gender of non-RA patients. And as I think most people are familiar with Mayo Clinic, a bit of a closed network even back at that time. So they followed patients even before they got diagnosed with the RA because that was their point of care, right? And then they followed them after they developed RA and just simply asked the question, what type of cardiovascular events do RA patients have compared to patients without RA disease? And they made some interesting observations. So the first point was, yes, patients with RA are at increased risk for cardiovascular events. But there's something a little bit different about those patients. When they have cardiovascular events, it's a bit of an atypical presentation. So how do they present? Silent myocardial infarctions. When you look at ECGs, they have T-wave abnormalities or Q waves and contingent leads, all right, but never had the crushing chest pain, et cetera, all right? But they clearly had myocardial damage based on stress testing and echocardiograms as an example. Patients with RA have a higher risk of sudden cardiac death, for an example as well. So atypical presentations. What was interesting is when you talk about angina, RA patients don't have as high a risk for presenting their cardiovascular disease with angina pectoris. All right? They're more likely to have an atypical presentation, but they're more likely to have cardiovascular disease from their high inflammatory state, and that's the point. Okay. Recent data from Corona in the US of over 25,000 patients also confirms this, that the risk of an RA patient for cardiovascular events increases as their severity of RA increases as well too. So again, the consistency of multiple sources of data support RA patients are at elevated risk for cardiovascular disease. When we talk about the heart, we move on to the lungs, right? So in autopsy findings, you'll find that half the patients will have some evidence of the rheumatologic process or RA process involving the lungs. So just like we had inflammation of the pericardial lining, what typically goes with that is the inflammation of the lining of the chest cavity or pleuritis or pleural effusions. I mentioned nodules in the heart, rheumatoid nodules in the lung, as you can see here on the X-ray. All right, granulomas, reflective of the rheumatologic process. A more concerning disease that 8 to 15% of RA patients can have is interstitial lung disease. So they have a restrictive lung disease, but if it becomes interstitial in 8 to 15% of patients, they now start having an oxygenation problem. So they need supplemental oxygenation, they need to be bronched for the diagnosis, intensification of immunosuppression, and in cases, you need to move to cytotoxic therapy like cyclophosphamide. So interstitial disease in a rheumatologic patient, an RA patient, it can be quite significant for them. But the point is, just like heart disease, lung disease, reflecting that RA is a systemic disorder. I'm going to briefly mention the nervous system involvement without figures. So patients with RA can get a rheumatoid vasculitis that causes a peripheral neuropathy. What's the problem there? But remember that patient I just talked about a little while ago, their joints in their feet and ankle were affected by RA, so think about that. So inflammation in their feet, some joint damage. Now on top of that, if they get a peripheral sensory motor neuropathy, they're going to have even further trouble ambulating, right? And now they're at higher risk for falls, hip fractures, shoulder fractures, what have you. Even if their hands, if they develop the peripheral neuropathy in their hands as well, they're even more impaired in what they need to do. So it's, again, tends not to be very severe, but it's an added complexity on top of a complex disease they already have. The cervical spine can be involved from RA. Again, that's not typical, it's unusual. We thought about that in a pre-biologic era more when their C1, C2 vertebral bodies were inflamed and eroded. So the problem there is that joint becomes unstable. So if they fall, if they get rear-ended in a car, which never happens, that joint becomes even more unstable and they start developing a spinal cord problem. So again, just a reflection that RA is a systemic disease. Now, skin disease in RA, this is not simply a cosmetic problem. A third of patients with RA will have rheumatoid nodules, all right? Where they'll have them is typically in the extensor surfaces around the elbows, on the dorsum of the hands, for an example. And so mechanically, those nodules can interfere with normal functioning of the muscles. Secondly, those nodules themselves can ulcerate and become infected. So now you need to have, again, IV antibiotics, surgical excision, and what have you. If you look at this picture of this individual, you can see back of their hand, they have a nodule there, and probably others, including in their fingers too. So again, joint inflammation, add on top of that nodules, they're not going to function normally. If you look at the ends of their fingers, you see purple dots there. In this individual, they've got a rheumatoid vasculitis, all right? So it's a systemic disease. So again, these hands, nodules, joint inflammation, joint destruction, vasculitis, I can't feel normally. Their level of functional capacity is severely impacted, particularly if they were doing a job with their hands. Eye disease, again, and this is the last organ system, again, it reflects that this is a systemic disease. Most commonly, it's a Sika syndrome, meaning dry eyes, but the concern is that there's also an autoimmune phenomenon too, with episcleritis, which is inflammation of the outer covering the eye, or sclera, which is the white of the eye, becoming inflamed and irritated. Again, those require a different type of immunosuppression than for someone who just has joint-limited disease. But the point is, again, another organ system that reflects that rheumatoid arthritis is simply more than just involving the joints alone. So why do we care? Well, if someone has extra-articular manifestations in another organ system than the joints, you can imagine that the therapeutic strategy to deal with that patient, to treat that patient, let's say lung disease or heart disease, is very different than someone who has joint-limited disease. Their monitoring for that organ system is very different than if they have joint disease. But one of the other reasons that we truly care is because we know from the data that when a patient has extra-articular manifestations, whether it's one, whether it's two, whether it's interstitial lung disease or nodules, they are at higher risk for mortality compared to patients who do not have extra-articular manifestations, as you can see here in the slide. So these are individuals which can make up to 40% of the RA population that probably need to be managed broadly in a very different way than someone who has joint-limited disease. Not only can an RA patient have extra-articular disease, but we know based off of data from the US and the Comorbidities study and then the Corona Registry that RA patients do have other comorbidities. A third could be depressed, over 20% having diabetes, a third have hypertension, and on and on. The point, though, is when RA patients have these additional comorbidities, certainly they are more ill. And it's a marker, once again, that these patients do not do as well as someone in the absence of those comorbidities, perhaps because that impacts the therapeutic strategy that the clinician can do with that patient, right? If they have a particular comorbidity, it may change what that patient or what that physician can do. Intensification of immunosuppression. They may not be able to use as much as they need to. So the RA disease continues to progress and they don't do as well. So RA patients, a significant proportion, have comorbidities. So it's not surprising that in a chronic, complex immunologic disorder such as RA, that in their milieu, in their immune system, and their cytokines, there's a lot going on. There's multiple cytokines, for an example, that contribute to the development of extra-articular manifestations. Again, on the slide you see common themes here of TNF-alpha, interleukin-6, somewhat of interleukin-1, for an example, the interplay there. So it's a complex disorder. So let me transition now into thinking about the 2015 American College of Rheumatology guidelines and the treatment of RA. Now, this relatively new concept of treating to a disease activity target, end of 2015, the ACR said and recommended that clinicians that are providing care to a patient with RA need to measure regularly the level of disease activity. Doing it once a year is no longer adequate. Why? Because I showed you in the earlier slide, there's a state of chronic inflammation. If it goes unchecked, joint damage, which is irreparable, and you also become at higher risk for extra-articular manifestations as well, too. So choose whatever of the 6 measures they recommend, but do it. All right? Now, implementing a therapeutic strategy or changing a therapeutic strategy, pick your disease activity measurement and do it. And in 3 months, again by the ACR guidelines, assess that patient. Is that patient in a state of low disease activity or in a state of remission? That's what the ACR wants patients to get towards. And if they're not there at the end of 3 months, that clinician should make a decision. Do you escalate or intensify their immunosuppression according to the USPI, for an example? Do you need to think about changing therapies within the same therapy class or changing mechanism of action? But you need to make a decision after 3 months. That's an adequate trial of whatever therapeutic strategy one's doing. But if you let that person continue to go unchecked with that level of inflammation, it's going to put them at more risk for joint disease and extra-articular manifestations. Now, as you can see here on the right part of the slide, again, that ACR is recommending that you get them into low disease activity. And not surprisingly, it's a chronic disease, so you're going to need to continue the immunosuppression. What's of debate still, and that's why this is a conditional recommendation, if you're able to get that patient in a state of remission, great. What do you do with the intensity of their immunosuppression? Can you taper some of it? What do you taper, how fast, and all those type of things. So again, it's an active area of research investigation. And the bottom recommendation here is, remember, it's a chronic, lifelong disease. Even though they may be in a state of low disease activity or in a state of remission, you're going to have to probably continue some type of RA therapy for that patient. So treating to a disease target. RA as a disease garners a lot of attention. It's not just simply an intellectual curiosity, it's in part because it's an expensive disease. because it's a lifelong chronic disease. If you look at the direct costs, they've been estimated to be over $11 billion. If you add in indirect costs, you double that amount. And then when you think about the quality of lives of these patients, the premature mortality that RA patients have, the costs go up even further. So for a complete discussion about cost, it's not just direct, it's not just indirect. One needs to think from a societal point of view, these other costs for that patient. So how does the level of disease activity of RA relate to the cost of RA itself? All right, and so that's what we want to talk about here in the next 3 slides. With recent data that have been published last year, and in fact only I think about a month ago as well too, that consistently show in the United States and North America that the higher your disease activity of RA, the higher your utilization of healthcare resources will be. Those observations are consistent with what was already known in Europe, but importantly, we now know from several studies that's true in the United States in contemporary management of RA patients. So the first study that showed that the level of disease activity, or a recent study that showed the level of disease activity determines or is associated with healthcare utilization, came from the Corona Registry. So Corona is a consortium of rheumatologic researchers in North America. They took almost 2,000 RA patients. All of them had been on some type of DMARD, biologically naive, and now we're initiating a TNF inhibitor-based therapy. And these investigators looked at the subsequent year of healthcare utilization. They categorized patients by their level of activity of RA using Clinical Disease Activity Index, or CDI. And so by the lowest level of activity, they categorized patients. So this population of almost 2,000 adult patients, just to give you a sense of them, only about 30% of these patients in this population ever got into a state of remission that was sustained or sustained low disease activity, only 30%. About a third of those patients as well had to switch in that first year. Half of those people that switched cycled to a second TNF inhibitor, and the other half went to some other non-TNF-based therapy. So I just want to give you a sense of that population here. So as you can see here in the slide, rates of hospitalization, rates of joint surgeries, and utilization of radiographs. If patients who had a persistently high degree of activity, moderate to high degree activity, when you look at their rates of hospitalization, they were statistically higher than those patients who were able to reach a state of sustained remission. And in fact, if you're only able to get them into low disease activity, these patients here had statistically higher rates of hospitalization compared to sustained remissions. Now that's consistent for joint surgeries as well as radiographs. And these observations persist when you go through an adjustment process. 2,000 patients, first year after TNF inhibitor therapy, there is a clear association in this observational study that their level of disease activity is associated with the degree of utilization of resources. A second study that just came out about a month ago, a different investigator group in the United States asked the same question, but the however was, remember I made mention earlier that RA patients have associated comorbidities, right? So maybe that healthcare utilization is simply being driven by their higher level of comorbidities. So what these investigators did from Corona, again, took data from over 4,500 RA patients, categorized them by CDI according to really their best CDI that they were able to attain, and then looked at, in this picture, rates of hospitalization, but they did the same for emergency room visits and mortality. And when you look at this population as a whole, again, over 4,500 patients, 43% of them were on some type of biologic therapy. Not surprisingly, 85% of those patients were on some type of TNF inhibitor. All right. 40% of patients during this time were able to get into a state of remission or low disease activity. Again, so the majority of patients in this population were never in a target recommended by the ACR. So when you look at their results, they, in this study, confirmed that the level of disease activity here is associated with the rates of hospitalization. So you can see across these clusters of comorbidities, and I'm not going to go into the principal component analysis of how they devise these clusters, but suffice it that these are less ill and these are the most ill patients. But no matter what level of comorbidity or burden of illness they have, you still see that the level of disease activity, as it increases the rate of hospitalization independent of their level of comorbidity illness. And the people that have the highest rate of hospitalizations, not surprisingly, are the people who are the most ill, but then also have the highest disease activity. So this was an important study, an observational study, because it's a bit more of a diverse sampling of the adult RA population in the United States today. Confirming what we saw in the earlier study. Level of disease activity significantly associates with utilization of care resources. Now, the third and last study comes from our neighbors in the north, and they used data from about 1,000 patients from the Alberta province, from a biofarm, and they linked clinical data with provincial governmental data, asked the same question. Used a different activity measure, okay, so DAS-28, disease activity severity of 28, and CRP, and categorized patients to whether they were able to get into sustained remission or sustained low disease activity, et cetera. This is still predominantly a TNF inhibitor-based population from a biofarm. About 20% of patients were able to get into sustained remission or sustained low disease activity. Again, once again, most patients were not in a target that the ACR recommends. And when you look at these data in terms of 2008 Canadian dollars, for patients who had persistent disease activity other than being in a state of sustained remission, you can see the total cost in dark black, if you will, was twice that than those patients who got into a state of sustained remission, driven in part by hospitalization cost as well as physician cost. Again, a third study in North America, consistent observations. Level of RA disease activity determines healthcare utilization rates, and in the study, cost. Importantly, it's consistent with even more data that come from Europe. So probably true, even though these data are observational data. So let me round out here some of the things we just discussed this morning. RA is a chronic systemic disease. It's a complex disease, an autoimmune disease. Not only is it a disease of the joints, it's also a disease of multiple organ systems in up to 40% of patients. Patients with RA certainly can have multiple comorbidities, so they're ill besides their RA. And we really care about the extra-articular manifestations because those patients need to have a therapeutic strategy and monitoring different than those patients who have joint-limited disease. The concept of treat to target has been now recognized in guidelines, so we expect that this will continue to be emboldened in the clinical practice of rheumatology over the next several years. Unfortunately, it takes time, right? These things don't happen overnight. But the fact that we just looked at data across several observational studies is, why does treat to target matter in a disease activity? Because you have higher healthcare utilization, right? That provides some rationale for why the level of disease activity has been incorporated in the American guidelines as well as the European guidelines. Disease activity measurement, pick whichever one you want to. Some are more complicated than others, but do it. And after 3 months, if that patient has not gotten into remission or low disease activity, you need to make a decision. Time is bone. It's irreparable. Continued unchecked inflammation, you're going to have other organ systems involved. Make a decision. That's really what the guidelines are really emphasizing. And lastly, as we just talked about several observational studies, again, healthcare utilization rates and their cost, we know increase with increasing levels of severity of RA. And so with that, I thank you for your attention this morning, spending some time with me today talking about RA. And with that, I'll end and open things up for questions. Thank you.